Good morning and welcome everyone. For those of you who don't know me, my name is Terry Moore and I manage our health policy practice at Abt Associates. Thank you so much for being with us this morning for our fourth event in our Bold Thinker series, the ACA at 5 years. Do Americans have better access to quality care? Just one quick programming note before we move on. Unfortunately, Mark Miller, who was to be on our second panel, can't make it this morning, so he sends his regrets. If you're on the webcast and on Twitter and want to join the conversation, please use the hashtag ACA_forward. At Abt Associates, our mission is to improve the quality of life and economic well-being of people worldwide. And for over 50 years, our work has been used to inform health policy, practices, and programs. We bring innovative solutions driven by evidence to improve the health of individuals, families, and communities. Today, we've gathered a truly impressive group of some of the nation's leading experts on health reform to discuss whether the Affordable Care Act has fulfilled its promise and how delivery system reform is shaping the future of healthcare. We hope today's discussion will generate some bold thinking and some new ideas about the key issues facing the health system today. Without further ado, it is my great pleasure to introduce Dr. Richard Frank, who's the Assistant Secretary for Planning and Evaluation for the U.S. Department of Health and Human Services. In this role, he advises the Secretary on the development of health, disability, human services, data and science policy, and provides advice and analysis on economic policy. Dr. Frank is on leave from his position as the Margaret T. Morris Professor of Health Economics in the Department of Healthcare Policy at Harvard Medical School, a position he's held since 1999. From 2009 to 2011, Dr. Frank served as the Deputy Assistant Secretary for Planning and Evaluation, directing the Office of Disability, Aging, and Long-Term Care Policy. His research is focused on the economics of mental health and substance abuse care, long-term care financing policy, and disability policy. In his role as advisor to the White House on healthcare reform, he was instrumental in helping to extend mental health parity to millions across the nation. Welcome, Dr. Frank.
Thank you. I really appreciate the invitation, although I must say I'm a little bit puzzled. Bold thinkers, why would you invite the ASPE? if really that's what you were looking for, I just, not sure. Anyway, I'm thrilled to be here. I'm going to touch on three things. First, I want to touch a little bit upon what I think are the important gains that we've made. Just to remind you, on the 23rd, we're having an anniversary of the ACA, so that'll be 6 years. Second, I want to touch a little bit on changes that we've made to set a platform for the future. And then the last thing I want to do is I want to touch on some important issues that we need to wrestle with going forward. And then the last of the last remarks will be sort of something aimed at researchers, because I know there are a lot of them in the room here, and in a sense that's what Abt does, and I just have, speaking as a health economist, will have a suggestion to make. So let me start with the gains. You probably saw about a week and a half ago, 20 million people have gained coverage as a result of the ACA. The gains have been broadly shared across the population among race, ethnic groups, and those gains are disproportionately concentrated among poor, disadvantaged people who were previously uncovered. As Bob Greenstein says, this is like the most important anti-poverty program we've had in a generation. The key pieces that have driven that are the marketplace, where we have almost 13 million plan selections during this year, at the end of this year's open enrollment, and the increased take-up in Medicaid since 2013 has been about 14 million people. This has been done in the context of overall spending growth that has been remained modest, even as we've expanded coverage and brought in millions of people that were previously uncovered. Last year we came in at about 4.3% in per enrollee spending across the country, and the evidence suggests that the higher overall spending growth in 14 has moderated in 15. Medicare in particular, spending growth has remained relatively low, in the neighborhood of 4 to 5% annually for total spending, and between 1 and 2.5% in per capita spending over the last few years. And preliminary data from 2015 suggests that growth per capita is going to be at the low end of that range when we get the 2015 numbers out. Our initial steps at delivery system reform are producing some positive results. The readmission program has resulted in net reductions in readmissions of 565,000 people with only modest unintended consequences. Recently, we had a paper in the New England Journal of Medicine that showed that even though there were some more increases in observational stays, net things came out quite positive in spite of that one untoward response. Similarly, our efforts to reduce hospital-acquired infections, decline of about 17%, is also relatively impressive. The ACO program is growing and yielding some savings, but progress is slower than some would like. Yet we're strengthening the incentives as the program matures. Currently, we have a proposed rule out for comment, and what that does is it sets up new rules for rebasing the program that strengthens the financial incentives for cost savings and quality improvement. Finally, our efforts at bundling are showing some positive results. Now, I'm especially proud of, and you can probably tell from the introduction, it's about the way we've dealt with vulnerable populations. This includes important gains in coverage for people with mental and addictive disorders, including efforts to integrate and coordinate services. We are engaged in efforts to support people re-entering society from prison. This is a group that's particularly vulnerable. If you just think that they are the group that's at the highest risk of overdosing from opioids, because as they come out of prison and if they re-engage and with the drug culture, they are extreme risk for overdose. And by engaging them early and making sure that they're covered, we're moving towards preventing that from happening. We're incorporating the tribes in many of the advances brought about by the ACA, and we're using Medicaid expansion and the flexibilities in the Medicaid program that have been introduced by the ACA to reduce chronic homelessness. And while we haven't eliminated it yet, we're on the path to eliminating it. Now, let me mention 4 platforms for progress. Obviously, we've built one new market entirely, and when you think about it, in 2008, the individual market was an underwritten market with many plans with thin coverage that covered somewhere between 8 or 9 million people. Today, we have a market that between the individual market that's off marketplace plus the marketplaces, we're north of 20 million people in that market. It's not underwritten, and it is a real market. Second, we've moved to continue to evolve the Medicare Advantage program, and we're doing a variety of things to strengthen that and to make sure that it's paid appropriately. And those are 2 sort of fundamental building blocks for the future that we have to continue to work on. Medicare modernization continues. I always think when I talk to my colleague Joe Newhouse, wherever he may be, there he is, that he and I have both taught Medicare for a long time. And for many, many years, we never had to change our slides. In the last 7 years, we have to change our slides every year. there have been more changes in the last 7 than there were in the previous 40. And so it really is a dramatically different program than it was. And again, I think it's a platform for progress. Health information technology and interoperability are the third important platform. We're making efforts to make sure that information flows. We're getting high levels of adoption, and we're working hard on the problem of information blocking and getting some commitments from the industry to partner with us to keep the information flowing. And then finally, there's MACRA. The Congress passed MACRA. We are on a very aggressive schedule to implement it, and that is really going to be the sort of other side of the sort of payment revolution where the business was incomplete, and that will be very important going forward. Let me now focus on 3 challenges. The first one is competition. When you, in spite that many people think this is a big government effort, it's actually a market effort. And we have one big new market, and we've developed, and we're strengthening other markets in the process. Well, if you rely on markets, you rely on competition. And in order to make this whole thing work, we need to preserve competition. And what we see is a range of activities going from information blocking to new energy at the Federal Trade Commission to an examination of our own policies so that we can make changes and evolve our rules so that they best promote competition in the markets that we operate in. Second is information. We are awash in information and are working hard to get more and allowing it to circulate more freely. Now, we have quite a bit of work that's been done on developing ideas for making it possible and easy for providers to get information and for use information and to exchange information. We are way behind on the consumer side of that. And in fact, what we have is a variety of policies where we've inadvertently created impediments. And again, I think of Joe's recent work showing that some of the focal points that we set up in Medicare and in other programs serve to distort consumer choices and make the market less competitive. And so we need to continue to work on those to drive our markets towards a competitive place. Third area is cost growth. We still don't understand the basics well enough. How much of the recent slowdown is structural versus transitory still baffles us. What is happening to productivity change in healthcare remains a point of debate and misunderstanding. And those are both extraordinarily important for designing our policies, but also for understanding how successful the current policies are going to be in the long run. And we need to get a better handle on those if we're going to make progress. Final observation to researchers. I'm a health economist, and reflecting on the economics of the Affordable Care Act, it is striking how health economists got it wrong. And the places that the health economics community is deepest, employee-sponsored insurance markets, the individual insurance market, and the connections to the labor market are 3 areas where we actually got it wrong consistently in the lead up to the implementation of the Act. Our predictions were wrong. We misunderstood how people would view employer-sponsored insurance, how employers view employer-sponsored insurance. And I think it's time to step back and really re-examine sort of our understandings of those basic markets and those basic forces in the healthcare arena if we're actually going to contribute in a more constructive way than we have in the recent past. So I'll stop there and take a few questions. That means I'm done.
I just wanted to ask you a question about your last remarks. I'm Paul Heldman. I'm with HSP Partners. I wanted to ask you, you said that the health economists got it wrong. And I'm wondering, when you think about that, how the role of private exchanges figures into your thinking and how that might affect the employer market in the future.
I think private exchanges are another manifestation of sort of how we misunderstood things. In a sense, the simplest models just sort of said, okay, there's a very simple economic calculus, boom, we have another opportunity to get people covered, we're going to walk away from that market. And in fact, the fact that most employers, A, have not, and B, are less likely to today than they were 3 years ago, plus they're engaging in things like exchanges, suggest a somewhat different relationship than we had understood. And so I think that actually there's much to learn about those forces by understanding what it is that's driving people into private exchanges.
Hi, Judith Glassgold from the American Psychological Association. Could you talk about narrow networks and provider consolidation and its effect on competitive marketplaces in the exchanges? Briefly.
I could talk about each one of those, but which one of those three would you like to hear about?
How about narrow networks
Okay.
and consumer choice?
So I think that one of the confusions in the debate is, are we worried that there are plans with narrow networks, or are we worried about all plans being narrow networks? To me, the important thing is that people have a choice of a variety of insurance products, and that they can then make the price, quality, access trade-offs on their own. And so to me, it's what we want to do is monitor narrow networks at the market level, not at the individual product level. And I think there's been some confusion about that. I think there's a lot of evidence out there, there's emerging evidence out there suggesting that when there are narrow networks, it's not just high quality providers that get swept out. The distribution in the narrow network actually reflects sort of the quality in the local market as much as fairly well.
I'm Mike Chernew from Harvard Medical School, and I was wondering if you could
His
talk.
office is next door to mine at Harvard.
Right, that's
so
true. But we haven't
truth in
seen each other.
advertising here.
Gain some weight. No. I was wondering if you could say something about prescription drugs and what policies might be in the lurking, things like Part B or other types of drug issues that have got a lot of press.
Well, Part B is no longer lurking. A couple of things we've learned and are acting on recently. One is it's pretty clear now that the problem is not generic prices. So there was a period recently where there was a lot of hand-wringing and a lot of finger-pointing at the generic market, in part because of the headlines about this guy whose last name I cannot pronounce. And I think that if you really look carefully at the data on the generic markets, that is not the source of the cost increases. Today, Express Scripts came out with some data showing really that's very consistent with what we've been seeing, which is specialty drugs are really an important driver. Given that, that fits very well with the Part B demonstration effort, which is really focused on physician-administered drugs in Medicare, in part because the incentives were particularly in the wrong direction, and because that's where a high concentration of specialty drugs occur. And so for all of you who may or may not have followed this, we're reducing the incentive to prescribe high-cost drugs and increasing the incentive to prescribe lower-cost drugs among equally effective products. And then at the same time, we're putting a greater focus on value-based purchasing, in a sense, bringing in modern, in a sense, PBM principles into the Part B program.
I'm Dr. Caroline Poplin. I'm a primary care physician. Could you go back to the first gentleman's question and explain what it was that health economists didn't understand about employer-sponsored insurance?
What it is that they didn't understand? For example, let me just, most of the predictions about how the exchanges would grow, the difference between, for example, what we've seen and what has actually occurred is not in the number of people who would gain coverage. The major forecasts, Congressional Budget Office, our HHS forecasts, are right in line with one another. The predictions on how many people would get insured were like spot on. What is different is that there were expected to be, first of all, a disappearance of the off-market individual market, essentially, and a fairly large shift from employer-sponsored insurance into the exchanges. And it's those last two pieces that have not materialized. In fact, if anything, they've slightly gone the other way. Okay. Thank you.
Thank you, Dr. Frank. It's now my pleasure to ask the first panel to come up, and this panel will be moderated by Alan Weil, who's the Editor-in-Chief of Health Affairs. Thank you, Alan.
Good morning. I'm Alan Weil, Editor-in-Chief of Health Affairs. We're very pleased to be a co-sponsor of this morning's event. Pleased also to have had many opportunities to publish the good work of people at Abt. And today we're going to follow up with Richard's comments. Don't let his humility at the outset fool you. He is as bold a thinker as they come, and we hope to build on some of the topics he raised in this first session this morning. As we talked about today's event, we thought we would focus the first session on the health insurance exchanges, and at some level we will certainly bring in also the Medicaid expansion, but we're really trying to focus on how that market is working, what changes might come in the future that would affect the ability of the constellation of programs designed to serve low and moderate income Americans with health care. And so what we've decided we'll do is have relatively brief opening comments from our panelists. I'll begin with some questions, and we'll have a little discussion up here, and then as time permits, we'll open it up to the rest of you in the room. We're going to go right down in the order of folks sitting here. You have full biographies in your materials, but Karen Lynch is the president of Aetna and is going to lead off by talking some about the perspective of the company on how the system of exchanges could be improved. Peter Lee is the executive director of Covered California, which is the health insurance exchange setup, marketplace setup in California, and he has been quite vocal about some of the possibilities that we could achieve if we change some of the rules around how exchanges worked, and particularly some lessons perhaps for the nation out of the experience in California. And we'll hear from Stuart Butler, Senior Fellow in the Economic Studies Program at the Brookings Institution. He's given a great deal of thought to the role of states and the opportunities for federalism. Certainly the design and structure of the low-income programs in the ACA are very dependent on state decisions and the relationship between states and the federal government. So let me turn it over first to Karen, and let us know the view from Aetna.
Thank you, Alan. Good morning, everyone. I'm very delighted to be here. I've been in the healthcare industry for 30 plus years, and it is a constant, dynamic, and ever-evolving marketplace. With the Affordable Care Act, as you know, we experienced and will continue to experience unprecedented change. And as you know, the public exchange marketplace is beginning, in our view, to deliver on the promise of transforming the individual insurance market, which really brings us to why we're here today. As you know, exchange enrollment isn't where we had anticipated it would be. We're in 2016, we're 3 years into the program, and with any new program, we've had a good amount of learning that we have to consider as we evolve this program on a go-forward basis. While the CBO had projected that we would be 22 million members in 2016, we only have 12.7 million members that came in through the open enrollment period, and official estimates are that we'll see only 10 million members by the end of 2016. So why aren't we seeing the enrollment? Well, first I'd offer you a couple different perspectives. One, I think it's affordability. And I would offer you that in order for us to grow exchanges, we need to enhance the overall affordability for competitive price points. I think it's really important that we have new models of provider collaborations. And I think what you'll find, and I'll talk about it in a minute, is what we're doing that is innovative and creative on the provider collaboration front. Value-based care focused on paying for more healthy days is critical to achieving success, in our view, for the exchanges. Right now, Aetna has about 37% of its medical costs in value-based coverage. Our goal is to increase that to 75% by 2020. And we have a couple examples that we have already started transforming the healthcare system. In Northern Virginia, our joint venture with Inova Health System is an example, a very good example, how collaboration with providers is producing health benefits for both our patients and for our consumers. Inova Health System reduced the readmission rates by 21%. This has led to healthier patients and lower costs for everyone in that system. Our collaboration with Banner Health System in Arizona has improved cancer screening rates, and we've seen reductions in diabetics with poorly controlled blood sugar levels. We're very pleased that CMS deferred the network adequacy requirements because we thought they were more stringent than the NAIC. We believe the NAIC strikes the right balance between ensuring access for consumers and being able to create more affordable products that rely on innovative provider relationships. I'd also comment that it's important to change and evolve the risk adjustment pool. Policy changes are needed to improve that overall pool because what we're learning is essentially that the program, that the zero-sum nature of the program, we're actually we're robbing from Peter to pay Paul. Some of the healthiest people in the program, where we have 90% of the healthiest people, are paying for the 10% who have those chronic conditions. So both cohorts, both on the healthy side and on the chronic side, are losing money. And I think that it's important that we improve health of all of our members by building long-term relationships with each customer. Consumer engagement is critical to the success of this overall program. And it's important that consumers have choice and engage in their health and their health journey over time. I would also offer that innovation is critical to ensuring the long-term sustainability of the exchange program. Exchanges, as you know, are very new and they're evolving. And we're still trying to learn more about the individuals that have enrolled. And because we need the program to mature, we need to enable our ability to have innovative benefit designs, new provider relationships, and technology to achieve consumer empowerment. I want to give you an example of why we think choice is really important. In the 2016 enrollment year, we introduced new consumer products and tools into the marketplace in 4 markets. Those markets were Phoenix, Charlotte, Southeastern PA, and Northern Virginia. We simplified the product designs. We eliminated co-insurance. We used technology for the an online shopping enrollment experience. And these products generally did well in 2016. But the question we have to ask ourselves, would we have been able to do that if we had standardized products? Perhaps the answer may be yes, perhaps the answer may be no. It's not clear. But what is clear to us is that through our consumer research, 59% of consumers expect insurers to innovate and to create new and better approaches. And 74% of those consumers wanted personalized designs so that they can be met on their health journey, where they wanted insurance to meet their needs. If you think about it, I have very different needs than Alan. And so I want to be met in my healthcare journey and have the choice and the products to meet my needs in healthcare. So we're a little bit concerned about standardization. We do believe that engagement of consumers is important, and we're in the process of continuing to innovate new products and designs to engage the consumer and working very closely with providers to do so. So I'd leave you with this message. We believe in innovation. We believe that the risk adjustment pool needs to be evolved and modified. And we believe in transparency and consumer choice. Thanks, Alan.
Great. Peter.
Thank you, and good morning. It's great to be here, and I really love following Karen because it's a foil on some of the issues. So I'm from California, run Covered California. We're the largest exchange, state-based exchange in the nation. We have about 1.5 million people enrolled. We have 12 health plans throughout our state, but they range in some regions from as few as 3 health plans to as many as 7. And we were asked to talk about what's doing well and what needs improvement. And I'm going to focus on 2 things. First on risk mix, and second on the delivery system. So first, risk mix. There's 4 factors to me that go into making a good risk mix, which is what makes a market work. They're affordability, policy choices, doing good marketing in the product itself. And I want to agree strongly that the number 1 thing is affordability. In Covered California, 90% of our enrollees have subsidies. They would not be buying insurance if not for the federal subsidies. Those subsidies mean that many are paying $20 a month, $80 a month. It's income adjusted, as you know. And also, affordability is about what they pay when they see the doctor. The cost-sharing subsidies are critically important. So affordability has, in California, brought over 1 million Californians into the marketplace that weren't there before. That improves the risk mix. Second, policy. California is one of the very small number of states that 2 years ago ripped the Band-Aid off and said, all of our products in the individual market must be ACA compliant products January 1, 2014. For those of you who don't know this, 35 states didn't do that. That meant that the individual market in those states was split between common risk pool with reinsurance, et cetera, and those off exchange, underwritten, previously underwritten, not part of the common risk pool, which was, I think, a bad policy call. That's going to work through those 36 states in the next 2 years. Other policies like reinsurance, to my mind, has worked brilliantly, providing a subsidy, in essence, to get a leg up, to get a better risk mix. Risk adjustment, though, and this is why we have the opportunity to disagree, it should be zero-sum. If some plans think it's the old game of trying to get healthy people and that's how they win, I want to take money from that plan and give it to a plan that gets more diabetics. It should be zero-sum. If it's not zero-sum, some taxpayers or others are paying the difference. Not a bad formula. I mean, I think a bad formula. Finally is product. There's a lot of discussion about standardized benefit designs, which I think is the wrong discussion. Covered California has patient-centered designs that all of our plans has to offer. Let me tell you what I mean by patient-centered. And we love innovation. We innovate a lot. Is in California, at the silver benefit design, every one of our plans offers the same product, and we sit down with plans and actuaries to design them. But it means that if you want to go see a doctor at a silver design, you don't have to spend your deductible first. Okay? In 30% of the exchange products and in 30% of employer products, before you get to go to your primary care doctor or your specialist, you need to meet your deductible, $3,000, $4,000. You hear a lot of discussion about high deductible plans. The issue isn't high deductible. The issue, what's subject to the deductible. In California, none of our people, 70% have silver or above, have to address their deductible before seeing their primary care doctor. That's phenomenally important. They can also make apples to apples comparisons. And we've innovated. Last year, we launched in our benefit design a product, all of our products for all of our plans, that if you're a consumer that needs to get Sovaldi. Now, another panel will talk about high-cost drugs, a really important discussion, but Sovaldi, $25,000 a month for 3 months. Okay? Without standard benefit design that addresses it from a patient perspective, that means as a patient, you would need to meet your maximum out-of-pocket in that first month, $6,000. If you're relatively low income, you'll go without the drug. We, having innovative design, said maximum copay $250, no matter what the drug costs. That's a patient-centered design. We allow our health plans to come in with alternate designs if they care to. But I would challenge everyone to kick the tires of health plans to say, is a personalized design ever one that puts $3,000 between you and your doctor? I don't think so. So patient-centered design is critical. Those factors meant that in California, we had the best risk mix in the nation. We had 2 years running of average rate increases, and I don't mean the lowest silver increase, I mean the average rate increase of 4%. Not one of our, well, one of our plans lost a tiny bit of money, tiny bit. Most of our plans made money. Our plans contributed to the risk corridor program to the tune of about $200 million. So when you hear about plans that lost money around the nation, I would look to what they did wrong for pricing and the challenges with the risk pool in terms of that decision about transitional plans. So that's on risk mix. Second, delivery system. I could not agree more with Karen that in the end, addressing costs isn't about the risk mix, it's about changing the delivery system. Delivering care more cost effectively, higher quality, right care at the right time. And I'll tell you, we look at that because 30% of our people turn over every year. That's the nature of the beast in the individual market. People, and we've surveyed, we know that our people, when they leave covered California, they don't go to be uninsured. They go to the employer market. They go to Medicare. They go to Medicaid. So we care about the entire delivery system. Well, I'm not doing slides, but I brought some samples here of, this is a 40-page contract addendum that all 12 of our plans have to enter into. And it lays out our expectations of our health plans for changing the delivery system. And I'll give you 4 small examples of that. First, every one of our plans needs to make sure that their enrollee, our enrollees, have a primary care clinician within 30 days. If you don't have a doctor, you're going to go to the ER. We're changing payments. Our plans in 3 years have to have 6% of their hospital payments in play for quality. We're looking at excluding, having our plans exclude outlier hospitals that provide poor quality care or very expensive care, or telling us why they need to keep them in. That's moving towards higher value. And finally, I know we're looking at disparities. All of these elements are things that if we don't change the underlying delivery system, exchanges won't be, over the long term, being able to offer affordable care. So with that, thank you very much.
Stuart.
Thank you, and thank you to Abt Associates for making this possible. I'm very pleased to have a name tag that calls me a bold thinker. I shall treasure this always, and I intend to send copies to my 2 daughters to show them, because they don't necessarily always see me that way. If it had said cool thinker, it would have been even better, but anyway. Alan asked me to really sort of see if I could look ahead more and think about the future, and maybe suggest a couple of kind of bold ideas or bold ways of looking at the ACA, that the sort of the chassis or framework of the ACA. and how we could work within this to really make very significant effects on coverage and care in the future. So I want to try to do that. And really to focus on two things, maybe three if we have a moment left. But the first is to really look at this as an opportunity to fundamentally change the mix of medical spending and other spending in order to achieve health. We know, or should know, that achieving health care and achieving good health is much more than providing medical services to people. That when we pay attention to things like housing conditions, whether there's mold in the house, whether the rugs are slippery, this is directly connected with the probability or not of somebody entering the medical system and getting expensive care. So it's not just prevention, but sort of thinking about that mix. It's interesting to note that when we look at the mix of medical services in this country and how much we spend on it compared with social services, we are very much an outlier compared with most other countries, particularly the OECD countries. Roughly speaking, in this country, we spend about 25 cents on social services for every dollar we spend on healthcare services. In the OECD generally, it's roughly $2 of social services for every $1 of healthcare. It's a very different mix. They know something that we don't know, and it's not a big surprise that in many cases they get better outcomes, or at least as good outcomes at much lower healthcare costs than we do. Now, we're making steps already to, I think, move in the right direction and to think about this in the right way. Our focus increasingly on social determinants of health in general, of course, is a step in that direction. CMMI has recently announced, as you know, accountable health communities to actually encourage greater cooperation between health services and other services. We have the Community Health Needs Assessment for nonprofit hospitals that at least nudges them to start thinking about partnerships in this way, and not just investments, but relationships and connections with community organizations. But when we think about what we could do in the future, I think we could go a lot further than that, and to correct some problems we see even now remaining within the ACA. If you look at the payment systems, either through private insurance or through Medicaid and Medicare, we don't have a payment system that nicely aligns with encouraging the healthcare system to explore better ways of dealing with community organizations, other non-health services to improve healthcare generally. We've got to look at that carefully. As Alan said, I've been looking at this also with regard to the role of states and the role of innovation in the whole area of healthcare. If you look at Section 1332 of the Affordable Care Act, it does allow states to come forward with really quite radical approaches to how they change the structure of health services within their particular states and what they do by getting waivers simultaneously across the different programs, including the Affordable Care Act itself, to do things differently within an exchange system, even to do away with exchange systems if they wish. But there are limits to that. The administration missed a golden opportunity a few weeks ago to allow states that came forward with a range of waivers, say in Medicaid and Medicare and so on, they could have allowed the states to essentially combine the budgets of those programs to move money around between these different health programs. But instead, they said that the budget neutrality had to apply to each program in those. That was a missed opportunity. If we're thinking ahead, we should perhaps be thinking about allowing waivers not just across health services, but between health and other major programs like housing. Again, we're experimenting in that way in Medicaid, in demonstration programs. But if we really want to think about using the combination of the structure of the exchange system and allowing states very considerable latitude to engage in experiments across different services, we need to go far beyond simply waivers within an individual program or across different health programs, but also into areas like housing, social services. Let the states come forward with proposals to improve the health of individuals within their jurisdiction by mixing money across those programs. The second thing I would just quickly deal with, I got the nod from Alan, so I will do it very quickly, is that we have an opportunity. We've taken steps within the Affordable Care Act, within the exchanges, to start to deal with the fundamental inequities in the subsidy system for people to get coverage. We now have subsidies, as you know, outside of the Medicaid program, outside of the employer-sponsored insurance program, for people to get subsidies to get health insurance. But as all health economists, I think almost without exception, know, this is just a small step in the direction that we must go, which is to really transform the subsidy system, including the tax treatment of health care, the tax exclusion for employer-based insurance, to really get to grips with a fundamental reform of that. We have in the employer-based system a subsidy system through the tax exclusion that is exactly the opposite of what we would want to do. It provides the highest subsidies to people who are on the highest income, have the most generous plans, and the least to those that are at the lower income and have very modest plans. We need to fundamentally change that. We need to make the subsidy system, I believe, ultimately neutral between employer-based insurance and non-employer-based coverage through the exchanges. When I first came to the United States and walked into an office of Blue Cross and said, okay, I'm told that I need health insurance in America. How do I get that? They said, well, it depends who you work for. And I said, well, why would anybody want to set up a system like that? And yet that is for many people what we have. If we were to go down the route of making it neutral, then I think, to pick up on the last thing that Richard Frank said, we would be thinking more carefully about the role of employers and employer systems within the exchange system and within our healthcare system generally, and start to modify that role. Should employers have a preferred role or a central role? I don't think so. I would certainly like to see us move much more towards everybody essentially being in exchange plans, and that the role of employer occasionally might be to be an advisor, a place where you do financial transactions. It's very good at doing that. But we should not have a system where I am dependent, if I work for an employer, of that employer essentially determining my health care. So maybe, hopefully, that's bold enough for you for now. And system
Or at very least cool.
Very cool, yes.
Well, I may not be a bold thinker, but by getting everyone to speak only for their allotted time, I think I get the moniker of bold moderators. But in the theme of trying to be a little bolder, since we've picked that up, I am struck as I listen to all three of you that one of the barriers to the transformation that seems to be needed is this one-year insurance cycle. And if we're going to get bold, why don't we put on the table the question of why do we do this? Why do we have employers pick plans every year and do it largely based on price so that they have incentives to swap? Peter, you talked about losing 30% of your market every year. When I think of the health plans that are often held up as leaders in engaging with the population, Geisinger has a very stable population in central Pennsylvania. Kaiser has very high retention rates for their population. If we're going to be bold, and I should just add, Stuart, your discussion about investing in social services and the social needs of the population, the payoff on those is often years later. So let's get bold. Why not move to longer time horizons for our coverage contracts and decisions? Who wants to take that one?
That's exactly correct. You want generally to have longer term contracts. You want to have set up a situation where that's the case. I think as you go, we see in the federal employee program, fairly small turnover. You mentioned Kaiser. You know, when you're stuck with a person, in all probability for several years, because the employer is not in the way, or the person isn't changing, or the fact that somebody changes a job doesn't mean that they have to change their insurance, then things start to change. And I think that's exactly the right way to go. It would encourage more longer-term investment in the health of a person. I think it's also important, as I say, to look at the business models so that we can when we're looking at payments, either as an insurer or through the Medicare or the Medicaid program, to recognize that investment in a non-medical element has to be part of that equation and build that in. That's the other part of the same equation.
Karen, where does the industry, why did we start doing this, and what would it take to change it?
Well, I think it's a long-standing history. I'm still young, so I can't speak to how employer-based. No, here's how I would think about, how we have to think about changing our relationship. We have to remember that all healthcare is local. And we have to remember, I think, to Stuart's point, that it's important that we not only look at the provider systems, that we do look at the social determinants of care. We need to engage in the individuals, they need to own their health care journey. And I think that's where this choice comes into play. That people have different lifestyle changes, they have different needs at different points in their life, and they need choices around what they want for their coverage. And I think that that's probably the more important topic with respect to improving the health of America, quite frankly. As you know, we have an aging population. We are seeing a huge increase in chronic diseases. Obesity continues to run rampant in the United States. And I think, we all have a responsibility to own our own health and to be able to make those choices about about how we want to be covered and, what we want, how much insurance, so to speak, we want. But I think it's important that we work more closely with provider systems, and that, I always think about provider systems and us. We have one common goal, and that's to improve the overall health over a long period of time. And I think that as we're changing relationships with providers, we have that, front and center for us.
I think it's a really good question. And so before joining the Obama administration and helping set up Innovation Center, I actually represented very large employers. And remember, most large employers themselves have a lot of turnover. And so don't have an incentive necessarily to think about, if you represent the University of California, CalPERS, people stay a long time. But if you represent Walmart, or people turn over quite a bit. And I think that's one. Number two, historically, and this has changed, the big way health plans made money up till 5 years ago was avoiding sick people. That was the game. The Affordable Care Act is starting to change that. And I think it's the right question. I've worked with health plans, and some of my best friends work for health plans, but generally they aren't that innovative. With all due, Aetna's done some very exciting things, but they generally
I take exception to that.
They generally haven't looked at population health. They generally haven't looked at what are we doing throughout a community. They look at little slices of business. And I think exchanges are in a place not to revolutionize things overnight, but have contracts with all of our plans. I mean, again, an example, and this isn't just California's big. We're big, but we're 5% of the entire market in California, which public exchanges probably are, whether you're in Connecticut or in Washington, which 5% is big. And having all the health plans change payments to promote better care in the same way makes a difference. I mean, one of my worries is every health plan having a somewhat different patient-centered medical home problem. Yes, that's innovative, but that doesn't help a doctor and a medical practice saying, how are my incentives being changed to change things over the long term? So it's a somewhat different angle on your question, Alan, but the other thing I come back to California is we want our health plans to contract with ACOs. In the end, the continuity I care about isn't health plan continuity. Sorry, but it's provider continuity. It's doctor relationship continuity. And that happens with Kaiser, but increasingly it's happening with accountable care organizations. And I want people to know that at open enrollment, they may be able to change plans, but do that in a way they know they're keeping their doctor if they care about keeping their doctor. And that comes back to the narrow network question. I don't want every doctor in every network. I like competition amongst providers. That's by having narrower networks. But I want consumers to know what they're choosing. So in the end, I don't really care about people changing plans. I care about patients having continuity with their doctors, which we should all be providing.
Let me pick up on that last topic that Peter raised about innovation and what it is that we're really trying to innovate. So innovation is the watchword. We're all in favor of it now. Actually, Karen, I was struck not by the fact that 59% of your customers expect insurers to innovate, but 41% don't. And those are the people I want to know what's going through their mind. But since we're all innovators now, I'm concerned about sort of the replication of a problem that we thought we were getting rid of. And this goes to Peter's comment that historically it has been possible for insurance companies to have as basically a business model risk selection, and there were lots of tools for doing that. And from an underwriting perspective, we've gotten rid of that in the Affordable Care Act. But my concern is, as we're thinking boldly, and we're turning everyone into having patient-centered insurance design, which I think is a very clever name. I'm still not sure I know what it means. But aren't we just creating the possibility of as we've eliminated underwriting as a practice in the industry, basically having self-selection as you tailor individual products to individual patients, and they select themselves, setting aside the question of whether risk adjustment should be cost neutral or not, fundamentally our risk adjustment techniques are imperfect. So I guess my question is, how much innovation do we really want in insurance products if we're making progress now in eliminating this business practice of underwriting? Isn't there the potential that we're just going to recreate that and create a problem that we were on the way to eliminating?
Well, I think you have to recognize the bold changes that you'll see in delivery systems or in technology for that matter. And if there's, changes in, if you're thinking bold, changes in robotics or changes in the delivery where you can go online and have a conversation with your physician, we need some of the innovation to include some of those new advancements in technology in benefit designs to increase the quality of care as well as the affordability.
So, but I just want to push a little bit. I mean, there's no question we want to innovate in delivery, but if we innovate in insurance in ways that make those services available to some and not to others, and then people self-select between wanting one or the other.
People, I think, goes back to the conversation around consumers want choice, and I think they need choice, and you have to be able to offer a variety of different options for people, and I think that's what's important, quite frankly. And I think innovation, you think about, before a lot, you would have to do pen and paper. Innovation such as, online enrollment or shop, buy, and enroll experience is innovation. And giving people that opportunity to understand and be educated in a different way, I consider that innovation as well.
Peter, do you worry about this proliferation of products?
Well, we don't have it in California, and I worry about it a lot. I mean, I think that, look, I believe in the delivery system as the front line of having healthcare in America be more affordable, which means to me getting a doctor with a patient, primary care, ACOs, patient-centered medical homes, and have $3,000 between you and your doctor is going to do two things. One, you're not going to go to your doctor. Two, the healthy people are going to say insurance isn't a good value. They're going to leave the risk pool. It's a dumb design. Patient-centered, and so I would ask Karen or any health plan person to tell me that they've done surveying that personalized design that consumers want is $3,000 between them and their doctor. And let me give you three examples of innovations in the area of benefit design. One is getting rid of coinsurance. Noted by Karen. I totally agree that coinsurance is an awful, confusing thing consumers don't understand. We've generally tried to get rid of it in every way we can. And I'm also a little worried about that because CT scans can cost anywhere from $300 to $9,000. By getting rid of coinsurance, which we've done, consumers don't know how much the difference the cost is. I worry about that. And we got rid of them. So but that's a good innovation. But I'll give you two other examples, which I'm really interested in. Value-based benefit design, saying a person with diabetes will have a zero copay to see the doctor and a zero copay for drugs. we may hear more about this in the next panel. I'm very interested in it, but I want to see the science behind it. I want to see if it works, see how it works. And similarly, reference-based pricing for hips and knees. You know? Okay, you say, for those who aren't familiar, you say, we've looked at the average cost of a knee replacement in California. It ranges from $9,000 to $60,000. CalPERS pays no more than $22,000 or some number. That might not be it, but about that ever. That's reference-based pricing. I think that's a great idea, I think. But that's something I'd want to understand the numbers better, et cetera. Those are innovations in design, not tweaks on deductibles. And remember, 30% of health insurance benefit designs today in exchanges and in the employer market have a deductible in between you and your doctor. That's not innovation. That's playing the old game of risk selection and thinking that's how we're going to win, and I think we all lose.
So I'll share with you, one of our innovations was really designing a new product for diabetics. And essentially what we did this year was we structured that program and that product to go right at that population so that they received the appropriate services if they were pre-diabetic or diabetic. We waived copays, and we encouraged them so that they got their screenings. Now, it's too early to tell. We need to evolve. But to me, that's an innovative product. And it's different, and it's unique, and designed directly for someone who has diabetes and can offer that choice. That would not be a program that I would want, but it might be something that Alan will want because he's diabetic.
Well, and that I cannot.
That's a HIPAA violation.
It's not even a PHI, but I mean that sort of design is. I cannot celebrate that enough, including the idea, and this is where risk adjustment makes sense. Boy, I live for the day when I see billboards saying, Aetna, the right place to go if you got diabetes, and Kaiser saying, heart disease, which I've seen this in California. Kaiser has billboards saying, heart disease, we treat it right.
So I want to get Stuart in here because you talked about broadening, and if we're talking about diabetes, we should also be talking about housing. And the question is, at what point are we sort of expanding healthcare to encompass everything and risk adjusting it and individualizing and personalizing it? It sounds to me like a negative income tax or something like that.
Too much of anything is not really very good for you, including what you just said. I think obviously we want to try to move in that general direction, recognizing that the complexities of getting budgets to align, to braid money, that choices for people can be confusing. I was listening to Mike Chernew just a couple of days ago, who informed or reminded me that people can be paralyzed by choice, too much, and even transparency. Many people, I'm sure you feel, that say, well, if a $60,000 replacement is probably better than a $20,000 one, right? They must be better people. So there's a lot of issues associated with this. I don't think we have to necessarily know right now exactly what the ideal end result is going to be. We've got to start moving incrementally in a direction. And that's why I questioned what the administration has just recently done with regard to the ACA Section 1332, where it said, okay, let's keep the budget's neutrality measure for each program, not even across programs. That was a wrong step, in my view, that we should be gradually moving towards allowing more and more types of services to be included. What the ideal thing will look like, I don't know. I'm a conservative, I'm not a radical, We don't want to do everything at once. And so I think we have to go slowly in those directions.
But I think it's important for people to have, when I talk about choice, that they understand the costs of healthcare, and so that they can make choices that, we talked about specialty pharmacy and where it's done. There's big, differences, and I think people should have the choice that they know, what it's costing them, and I think that transparency is essential.
I could keep going, but I won't. I want to make sure that those of you in the audience have a chance to engage with our panel. We have microphones, so wait for those to come to you. If you're too shy, I'll keep asking questions, but I'd be shocked if you're that shy. Here we go.
Hi, I'm Caitlin Cross-Barnett from the Center for Medicare and Medicaid Innovation. And I had a question about innovation in practitioners and reimbursement for different kinds of practitioners. And I think this speaks somewhat to Stuart Butler's comments about integrating the social services with the medical services. But I'm hearing everybody talking about between you and your physician, and I think, a lot of people are adopting people like advanced practice nurses as primary care providers, and they can provide healthcare services and make referrals to physicians when the person is not, has health problems that need to be seen by a physician. But it seems to me that in payment, reforms and innovations, that thinking about using social workers, APNs, RNs, and different kinds of providers other than physicians would figure into that. And I was wondering what your thoughts were on that.
Well, I certainly think, absolutely. That's I think, a critical part of the equation, to look at people with different sets of skills that go beyond the strictly medical area into these other areas of what social services can be included. And I think I've been very interested in the role of, not just the role of nurses in that particular regard, but the role of intermediaries generally. Can there be individuals that can come into the equation that can help coordinate these kinds of services better? With the, as most of you know, with the imposition now of readmission penalties in the Medicare program, you're beginning to see hospitals saying, okay, when you leave, we don't just say goodbye and give you a stack of papers to comply with, but more and more hospitals are starting to get interested in how can they make sure that person doesn't come back again, and employing people, nurses, entering into agreements with intermediaries and so on. Washington Adventist Hospital here, not too far from us here, now has a contract with an organization called SeedCo, which will sign up, or investigate and sign up people for social services, including housing, assistance, all kinds of things that normally hospitals don't do. But it was encouraged by the readmission penalties, but now they've gone far beyond it to start exploring those areas. And I think when you start looking at the role of intermediate, Health Leads based in Boston is another example where they embed young people who know how to use computer programs in hospitals, so at discharge, there's an investigation really of what are the broader needs of that patient about to be discharged. And they will sign up people on the spot to other services and so on. These are all steps in a general direction of saying, in order to keep this person healthy, we don't just want to saturate them with physicians, or cut them open or give them pills. We've got to start building in these other elements. We're going in that direction. There are a lot of issues associated with the payments for a lot of these things that militates against it. But at least we're moving in that direction. So I would absolutely agree with you, but I think it goes even beyond that into how we can best coordinate all the things that are happening in somebody's life that is ultimately going to affect their health, and where that can be best done, whether it should be done within a plan, whether it should be done within a, say, Medicare Advantage plan for older people, whether it should be at the hospital setting, whether it should be a school nurse that's doing this for younger people. That's what we've got to really look at more thoroughly.
So, Alan, can I just
sure.
I would encourage you to go to our website and go to Article 4.03 of our contract, Integrated Health Models, which is, and we actually, I couldn't agree with you more, but part of the challenge about innovation is right now, there's been a lot of work on ACOs and patient-centered medical homes for years, and even today in California, most of the health plans have different definitions of what an ACO is, and different definitions of what a patient-centered medical home is. And we're laying out for our 12 health plans, we expect we're going to have a benchmark of how many people of our people are in a standard-defined, population-based coordinated care across physicians, ancillary providers, and hospitals. How are they sharing incentives? And we need, and this is some of a national question, is that it doesn't help health plans or providers to have different definitions. Now, this is one of the challenges around innovation. We want innovation at delivery, but we need, a smaller set of measures and a clearer set of standards that we're paying for. And so we need to push in that direction. Innovation Center is doing great work, but we out in the field need to be sort of marrying up with that.
Peter, you talked about transitions from your exchange products into the private market, into Medicaid, I assume. I just wondered, one of the hopes for the ACA was that we could smooth out that transition between Medicaid and the exchanges. And since Alan had promised us a chance to talk about Medicaid, I wanted to ask that question.
Great. So, well, now this is the time for true confessions. Transitions go both directions. So about 1/3 of our people leave, which meant last year about 650,000 people who had insurance with us left. The biggest group of them left for employer-based coverage. The next largest to Medicaid, then Medicare, then other individual. And I'll note, 15% left to be uninsured. I worry about them, but 85% got coverage. And I would postulate that in areas that don't have patient-centered benefit design, which is, you're much more apt to have a higher percentage of people leaving to be uninsured. That said, we do a lot of work with Medi-Cal, which is the Medicaid program in California, to do good transitions so there's continuity of care when they move from us to Medicaid. It's not as good going the other direction. And that's where Medicaid, and we're talking about exchanges, but let's remember that there's been more people who have gained insurance because of growth in Medicaid than because of the exchanges. California's Medicaid program now is about 13 million Californians. 1 out of 3 Californians under 65 is in the Medicaid program. Every month, people are leaving Medicaid, going to job-based coverage, coming to us. We've got a lot of work to do there, and we're still working on the systems to make those handoffs so people don't lose continuity of care when they're having the continuity of coverage. And this is, again, back to we're early on, but it's one of the challenges that our exchange has, I think all the exchanges have.
Could you just speak to the similarity between the Medicaid plans and your exchange-based plans?
So the question was the similarities between the Medicaid plans and the Covered California plans or products. There's overlap. We actually reached out to Medicaid plans to be in the exchange to facilitate that. Many of the big Medicaid plans in California are very, very busy. They're doing the duals, et cetera, and had too many balls in the air to also offer products in Covered California. But LA Care is in both. Molina is a plan with different networks, is in the Medicaid market in a big way in California, and now has over 85,000 lives in Covered California. Not identical networks. And so the issues of what you're paying in Medicaid versus what our plans pay in the Covered California market, it's not the same payment, it's different networks, but there's more overlap. And so that's one of the issues, whether, again, wherever you move, continuity of care, but there's overlaps, but not identity of networks.
Stuart, do you want to talk about the opportunities under 1332 in this regard?
With regard to Medicaid?
With the alignment between the two.
Yeah, well, as I said earlier, that in principle, the Section 3032 allows a state to come forward with multiple waivers to align the services and to do something innovative, providing that there's budget neutrality for the federal government. That's the basic design. As I said, I think one of the concerns I have is that the rules, the most recent ruling on these applications, say to states that budget neutrality will be only within each program. And that immediately sets up a barrier to creativity across these programs, including the ACA plans themselves. And I think that's a step in absolutely the wrong direction. States, a number of states were ready to come up with some very interesting proposals along the lines that we're talking about, but are now not going to do it.
For folks that aren't familiar with that, I won't speak for or against it, but it is absolutely true. The guidance issued by HHS was a very narrow guidance.
Yeah.
And so the pathway, and Covered California, part of the state, is looking at 1332 waiver options. There aren't many, given the guidance issued. There'd be a lot more issues around continuity between us and Medicaid if we could look at things together. I mean, I'll just tell you, the one thing that advocates are pushing us to do is to expand offering unsubsidized coverage for undocumented Californians. And there's good pros and cons. It doesn't touch the federal budget because it's not subsidized. People can already buy it off exchange, but there aren't many things you can do without bridging those programs.
Exactly
and that's
right.
The next administration, whoever that is, will have the opportunity to change that guidance. And I think that the law certainly provides broader guidance than the current HHS provided.
So why don't we take one more question from the audience, and then we'll wrap up this panel. Who wants the last? Sir.
Yes, this question is for Ms. Lynch. My name is Carl Cooper. I'm with the American Association on Health and Disability. You're talking about shifting the risk pool adjustments, and I just wanted to know if you could give a little more specificity on exactly what you're talking with that. And based on your answer, I might have a follow-up.
Okay, so
Whether your answer is correct or not.
So what we're looking for, the way we've, all the data that we've been analyzing in the risk pool, what we've learned is that it's not a balanced risk pool, and that kind of the reimbursements of the sort of top end aren't covering what's necessary, and then they're sort of pulling from the healthy end. And so our view is that some of the changes that would need to be made are, changing some of the conditions, getting risk adjustment for preventative services, and also monitoring for specialty pharmacy as well. So those are some of the types of things that we would want to see change in the risk pool adjuster categories.
And the verdict is?
Yeah. I guess my concern is, doesn't that get around basically what the ACA was designed to do, which is not allow people with disabilities and chronic conditions to get priced out of the market? Because what you're describing essentially would end up doing that.
No, I think what it does is actually makes it more affordable. And the way it's working now is, the prices sort of are increasing because it's not a balance. And I think this would actually balance it out and make it more affordable, quite frankly.
I guess I'd have to see the specifics.
I'd be happy to share them with you.
As we close up, Peter, do you want to say anything about how standardization affects your concerns about risk adjustment? Obviously, you don't have it on the design side, but you can still have it on the enrollment side.
So again, my hobby horse is patient-centered designs. They don't have to be one design, but I think getting patients in so they get access to timely care is a big deal. There still is in California, some of the plans were big payers into risk adjustment. Some were pretty big receivers. And I think the technical issue of getting risk adjustment right is hard, and it's getting better and better. It doesn't affect, in California, I should say, it only affects the small plans. Some very small plans have been, for them, big payers, some have been big receivers. All of the big plans that have substantial enrollment are very close to being risk adjustment neutral. And to me, the fundamental issue of the Affordable Care Act is saying, let's pay adjustments for risk, but not try to enroll differently for risk. Unless you're doing, and I really cannot celebrate enough, get those billboards. Aetna, we serve diabetics well, come in, and then there should be risk adjustments from other plans that enroll fewer people with diabetes to Aetna, so they should get paid more, but it doesn't need to be price neutral. If it generally diabetics cost more and Aetna gets a lot more because you're promoting them, zero-sum adjustments is exactly what should be happening, but not zero sum. Who else is going to pay the non-zero sum? If diabetics cost more and you get more of them, hallelujah. But let's get the risk adjustment mechanism to work right. And again, I'd encourage people to look at the data. California has the best, as of 2014, risk mix in the nation. If you look at the scores from the Risk Corridor program, look at our premiums, look at our health plans having made money, and the issues about having enough money is pricing right and adjusting across the pool.
Well, as we finish this session, just a quick observation, a quick question. The observation is 2 topics came up, and if you keep your eyes on health affairs, you might find some answers to the question of how people respond to value
very nice plug, Alan.
Sensitive insurance design, thank you. And also how people view the price-quality trade-off, so keep your eyes open there. I'll just close with a rhetorical question that I know the next panel will answer, which is, if everyone's innovating and everyone has good models that are saving a lot of money, why is it that we continue to have this affordability problem? So with that, not so bold, but hopefully provocative question, please join me in thanking our panelists for the discussion this morning.
Thank you.
The first session dealt with the Affordable Care Act, which is 5 years old. We were asked in the second session to focus more on Medicare, which is 50 years old. Power of 10 seems to be operating here. The Medicare program is surpassingly popular in the general public, but it comes in for a fair bit of criticism and proposals for alteration among policy experts. Some of those criticisms go to the basic structure of the program. Some go to more narrow operational considerations. We have three very knowledgeable experts on the platform who are going to focus on the Medicare program, looking both at program design, but also on the politics of enactability. They're going to consider things that are practical, not just theoretical ideals. Michael Chernew is professor at Harvard University and director of healthcare markets and regulations at the Harvard Medical School. He is a member of the panel of health advisors of the Congressional Budget Office, and his name is closely linked to the idea of value-based insurance design. He's going to talk, among other things, about Medicare pricing rules and about incentive payment systems, such as those mandated by the 2015 legislation to which Richard Frank referred earlier. Bob Reischauer is going to follow him. Bob has recently stepped down as president of the Urban Institute, and also his full-time job as a member of the Harvard Corporation. That was an inside joke given the fact that that job was very time-consuming. Bob and I wrote a paper most of a year ago for a Brookings conference on Medicare reform, and I'm assuming he may refer to that. If he deviates too far from it, I'm going to be shocked and very much disturbed. Alan White, Alan White is a senior health economist at Abt Associates, working in their U.S. Health Division. He's the only person among the three here today who is not affiliated in one way or another with CBO or its history, but he has been recognized on a number of occasions within Abt Associates for his innovative and path-breaking work, having received awards named in honor of Daniel Bell, the distinguished sociologist and former Abt Associates director, and another award named for the founder of the corporation, Clark Abt. His work has focused on metrics for measuring quality improvement, and I assume that his comments are going to draw on that experience. As before, each of the panelists here will speak briefly. We will then have some crosstalk among us, and we look forward to your participation after that's done. And we're going to march right down the aisle here. Mike, you're leading off.
Great. So I'm thrilled to be here. So I'd like to thank the folks at Abt and Health Affairs for having this event. So let me start with a general premise, which is I'm going to focus on Medicare payment broadly. I'm going to stray into some alternative payment models in absence of Mark, and really you're missing out without having Mark here, but anyway. But let me start by saying a lot of the Medicare policy discussions are less about health and more about taxes. And at the end of the day, when we think about how Medicare payment models are going to evolve, it's really going to be focused on how we manage the fiscal challenge. So Alan, I'm not sure Alan is still here, but if he is, he raised this question of affordability. It was truly rhetorical with him not here. But in any case, there's a question about what's going on in healthcare spending-wise. It's growing. Will it continue to, will the rate of growth continue to be slow? My general view published in Health Affairs was that the healthcare spending slowdown was not due to the recession, but that does not mean that we will retain slow healthcare spending growth. Whether healthcare spending growth remains slow depends a lot on what we do. It's not something that just happens, it is something that we influence, and that is what's going to be important. Policy responds to forecasts. Regardless of what really does happen, policy will respond to the forecast of what's going to happen. The forecasts are that federal spending as a share of GDP is going to rise. Some of that reflects assumptions about the rate of growth in per beneficiary, but a lot of it, frankly, reflects the number of beneficiaries. Just to give you some idea, historically, healthcare spending has grown at 2 percentage points faster than income. Because of the demographics of Medicare, if you were able to reduce that excess rate of healthcare spending from 2% faster than income to the rate of income growth, which would be a historic achievement, you would still find Medicare spending as a share of GDP growing simply because of the baby boomers. So essentially, we have a fundamental fiscal challenge, which is we need to insure more people, encourage innovation, and do it at a price that we can ensure we can afford in the Medicare program. And we live in a world where we're averse to the taxes that one would need to support that. And I believe that's fundamentally what's going to drive Medicare payment policy. So it turns out, and I'm glad you all came here to hear the following bold statement, that one way to pay less is to pay less. And it's taken a lot of thoughtful people to figure that out. And if you look at what's going on, I'll say a little bit more in a little bit, but an enormous amount of what's happened is we have changed the current law baseline rate of increase for Medicare fees relative to what they had historically been. I'm going to say more about that in a minute, and then I'm going to transition to what I think is a broader point. No one is excited about that, and the excitement is all around not just simply changing the rates that we pay, but the way in which we pay, moving away from a fragmented fee-for-service system towards broader bundles across time and patient bundles. So about the general fee schedule, the Affordable Care Act said that instead of prior to having payment rates rise roughly at the rate of input price inflation, they now go up at the rate of input price inflation minus a productivity adjustment about 1%, which means if you're a hospital and nurses' wages are rising about 3%, you're going to get a 2% fee increase. And you have to make up the difference with productivity, or so it's called. That, of course, can be overridden. There's been some politics around whether it would be overridden. The key thing I will say is any effort to override that would require it to be scored. So we know a lot about the physician payment system that had been called the sustainable growth rate, which was many things but not sustainable. It was hard to get rid of because getting rid of it required it to be scored. You had to find pay-fors, and that became a challenge. We eventually replaced it with MACRA. And the interesting thing I find about MACRA is that the win, by and large, was flat physician fees. You get a 0.5% increase for a while, then you get no percentage point increase until about to 2025, then you get a smaller, about a 0.25 percentage point increase. So the win for physicians was essentially flat fees. There was some desire that we should try and do other things to make things work better. So there's efforts in the program to equalize payments, very small efforts right now to equalize payments across sites because these differences in payments from, say, hospitals, same service in different sites causes a lot of things go on the market we might not like, including consolidation. And of course, we always want to lower the prices for overpaid services. Defining which services are overpaid is always a challenge. The key point that I would make here is prices create incentives as opposed to simply reimburse providers or allocate funds. So the key thing in thinking about this is we want to control the rate of growth, but we also want to get the incentives right. Part of getting the incentives right had to do with promoting quality. If I hear value-based payment more and more and more, sometimes it really is value-based payment. A lot of times it's just something mildly different than what we currently have. But in any case, we instituted something called MIPS, which is the sort of quality model. The key thing there is some physicians can get paid more, some could get paid less, but it is basically, for the most part, budget neutral. There are winners and losers to this new model. So we are willing to pay more for quality, except for the fact that we're actually not. We have to finance it by taking money from somewhere else. And I actually don't see that changing, again, because to make it simply paying for better quality, you would then have to pay more, which we aren't really that willing to do. So now I'm going to lapse a little bit into some of Mark's material. So moving to some alternative payment models, we want to move away from fee-for-service and give the delivery system incentives to save money. The idea is that we will pay on more aggregate units. So there's global budgets, population-based payment models, if you will, things like ACOs, of which there's a whole variety of different models that are constantly changing. There's episode bundles, including the BIPC, which is the bundle payment for care improvement. There's mandatory joint model now. They're working on a cancer bundle model. And there's various medical home type models. It's a desire to get people in there. In fact, one place we will pay people more is if you move to these types of models, you can qualify for a 5% payment bonus for a while. And there's some other goodies if you move into these new models. I'm actually very supportive of that. I think the way to win here isn't worrying about what we're going to be paying in 2017, but setting up a system that will look and work well in 2027. So making this transition matters. I think it's okay if we spend some early on to get there. All these models have a few basic features. They transfer risk to providers, which has caused a lot of heartburn. They include some pay-for-performance quality component. We have a lot of work on measures. And of course, there's a lot of data support. The key point here is the way that we're going to win in Medicare is we have to have a system that allows providers to succeed financially if they do what we want and doesn't require us to pay them more. So these models allow them to convert their efficiencies into profits. That is, generally speaking, a good way forward. One thing you have to understand, all these models are typically called shared savings models. So again, in case it's not clear from the name, in shared savings models, the savings are shared. Oftentimes, we don't like to share the savings. We want to take the money out right away. The problem is if you don't share the savings, you won't have savings to share. There's a range of targets that HHS put out as to how quickly we would move there, 30% by 2016, which they met, incidentally. If you read the brief, you could debate their math. 50% by 2018. Some evaluations. So we've done some evaluations. You should just Google Mike McWilliams and you'll find some of my favorite evaluations. But in any case, the point is we found that the Pioneer model saved a little bit more than 1%. That's depressing to people who think there's 30% waste. My retort is if someone offers you $1 and gives you a dime, take the dime. You know, it saved money and all indications are quality improved, patient satisfaction improved. It's not as big a win as we would like, but it is nevertheless a win. So this isn't sort of an expectations game kind of thing. Let's work to get better, in part because the alternative isn't that great. So let me just sort of echo another concern that I had, which Richard Frank said a little bit about. There's concern that these models and a whole number of things will lead to provider consolidation. That is certainly true. I don't think it's simply payment. I think it's all of the data infrastructure, all the quality measurement, and some of the site-based payment inequities have all led to provider consolidation. That's not as big a problem for Medicare because it turns out they will just set the prices, but it is a problem for the healthcare system overall. And I really think we have to think about how we're going to deal with that, and maybe others will say something about that. But my summary is, I am not sure we can make some of these alternative payment models work. I know that the fee-for-service system is extremely difficult to get to work. We have a payment trajectory there that is likely to be very unfavorable to providers for a long time. So I think this is not will not be a mass migration to these other payment models because they're so wonderful. If we see movement in that direction, it will be because the alternative is going to be so challenging to people because you're looking at essentially largely flat payments through 2025. And even then, not that much increase. And that's nominal. So I just think we have to figure out how we're going to make these things work. If we can't get the delivery system to provide us care that we can afford, everything else we do is going to be doomed to failure.
Thank you very much. Bob?
Well, on that positive note, how can I go?
He's the skeptic. Bob is always more skeptical.
Yeah, right. No, I mean, I sort of had the feeling there at the time I was listening to Lewis Carroll and Through the Looking Glass, the play on words, and I was still trembling from the threats of our bold moderator that if I didn't talk about the paper that we had done, he would hold me accountable. I thought maybe I'm in a Trump rally here.
Just don't worry, Bob. Stay in line and you won't get beat up.
You know, the question that was posed for this event was, do Americans have better access to quality care 5 years after enactment of the Affordable Care Act? And as so often is the case when we come to questions like this about the effects of policy, the answer, if you're not a presidential candidate, is it depends. And it depends on who we're talking about, because Americans obviously aren't a homogeneous group, and what dimensions of access and quality you care most about. One can specify sort of three broad groups of Americans. You have the folks who are covered now, covered in the past, and covered in the future by employment-related health insurance. The second group, who all or most of the time are not covered by employment-related insurance, and as a result depend on Medicaid or on the individual market or go uninsured. That is before the Affordable Care Act was enacted. And finally, there's the elderly and disabled who are covered by the Medicare program, which is the focus of this panel. But I am just going to give a bottom line for the other two groups. And obviously, no matter what dimension of access or quality one thinks is important, the second group is clearly better off, those who were uninsured or were in the individual marketplace. Part of this, of course, is because the bar in the pre-Affordable Care Act era was so low, it's hard not to have an improvement, but we shouldn't belittle the fact that the policy changes were huge by historical standards of social policy change. I mean, the expansion of Medicaid, the creation of the state exchanges with the tax credits, and the relatively generous cost sharing for some people, and the fact that insurance is now both guaranteed issue and renewable for that first group of people, which is something that perplexes me. The majority that enjoy employment-related insurance and will until they retire, the benefits of the Affordable Care Act seem to be less apparent and certainly less appreciated, because still, 4 years, 5 years later, a majority of them express an opinion in public opinion polls that they would like to see the act either significantly changed or even repealed. I think most of these folks, on the whole, are ignorant of the ways in which they have benefited. They know that their kids are covered till age 26, and they love that. They know that they can't be excluded from insurance because of pre-existing conditions. But there's a whole lot more ways in which the Affordable Care Act has improved the quality and dependability of employment-related insurance that they aren't aware of, probably because these are dimensions that affect the average person so infrequently that they don't focus on them. But they include the elimination of annual and lifetime caps, establishment of reasonable catastrophic spending limits, required coverage for essential benefits, minimum standards for actuarial values, and limits on waiting periods, just to name some of them. And of course, many of those who work for large, well-financed companies had these benefits through their employers. Turning to Medicare, the Affordable Care Act made many significant changes, but for the most part, these changes didn't affect beneficiaries directly, but rather affected providers, MA plans, taxpayers, the delivery system, and CMS as an institution. These include the various measures to slow the growth of spending by reducing provider updates, the creation of new payment mechanisms, encouragement for new delivery systems, and the establishment of financial incentives to improve quality, and finally, the development of new capacities within CMS. However, from the Medicare beneficiaries' perspective, the Affordable Care Act made very few changes to the program, and for the most part, these changes had a sweet taste to them. For example, there's reduced cost sharing or elimination of cost sharing for preventive services, and the notorious donut hole in Part D, which will gradually be filled. I actually came up close and personal to it in December of this year and was rather shocked in the Safeway pharmaceutical line there when I got how much I ended up having to pay. Because the Affordable Care Act did so little directly to affect Medicare beneficiaries, much remains to be done to bring the program into the 21st century. It's a fact that after the Affordable Care Act reforms that affected both Medicaid and the employer-sponsored world, Medicare, in fact, became the laggard in a number of ways, and we have to decide sort of what's the agenda looking forward for changes to bring it into the 21st century. Let's start with just mentioning a few of the limitations of the program as they exist, and obviously one is the complexity of the program that leads to a lot of confusion in decision-making by beneficiaries. Medicare, as you all know, comes in parts, and besides Part A, beneficiaries get to choose whether they want to join Part B and or D, and those are voluntary. They involve premiums, and the premiums vary a bit according to your income. This makes things confusing, but even if one accepts the whole kit and caboodle of A, B, and D, it is a system that, by today's standards, provides inadequate protection and leaves beneficiaries exposed to the risk of high costs. This is for two basic reasons. The first of them is that there is no catastrophic protection. The only part of the American insurance system which isn't required to have catastrophic protection, with the exception of Part D, which does. And secondly, because there is significant cost sharing in the Medicare program, which people don't always appreciate. There's just one example would be in the hospital area where there's a deductible equal to the first day's cost, average cost, which is over $1,200 a year. And because of this financial risk resulting from inadequate protection, over 90% of the participants in this program feel the need for additional kinds of insurance, namely supplemental coverage through Medigap, through an employer's retiree policy, through Medicaid, the VA, or by choosing to take their A, B, and D benefits through a Medicare Advantage plan, which will offer more in the way of coverage. Henry said that he and I had wrote a paper about a year ago saying, well, where should we go in this, given the deficiencies of the current Medicare program from the beneficiary standpoint. And we came up with a fairly straightforward and simple set of recommendations, ones that others have talked about and analyzed before. First, we, like others, would consolidate the three components, A, B, and D, into a single plan. So you had that plan. There wasn't the ability to take pieces of it. We would also infuse the basic Medicare program with a catastrophic cap and bring it into line with all the other insurance that is available in the United States, but with one difference, and that is that the catastrophic cap would be defined in terms of the beneficiary's income rather than a flat amount of money. This 10 years ago would have been an inconceivably complex administrative problem, but thanks to various changes that have taken place and with the ACA, we are building the capacity within government to do something like this. We now income relate Part B and D premiums, although admittedly this is just for the very, very high end where the IRS has up close and personal relationship with these people, but also we have the capacity that has been developed for the premium structure within the exchanges, and we have the low-income subsidy amounts both in the drug and the standard Medicare plan for very low-income people. So we're doing a lot of this already, and a catastrophic cap defined in terms of a percent of people's disposable income makes a whole lot of sense. Henry and I also thought that the future of Medicare should come in two flavors. This flavor that I've described, basic Medicare, but we have a whole lot of evidence that the average beneficiary wants much more than that. This is why they go out and buy the Medigap or the employer policies. And Medicare, therefore, should be offered in the two flavors, the basic and then one with a lot more cost-sharing help. This shouldn't impose excess costs on the taxpayer. It should be funded either by moderating benefit structures and obviously increased premiums. And the increased premiums, of course, have rationale in that the individual who chooses to go this route will not be paying Medigap premiums or employer retiree policy premiums if they have to, or the employer won't have to. And so there's a certain amount of just transfer of resources, but all of this would lead to a system that was much more adequate and a whole lot simpler to administer and more equitable.
Thank you. Alan?
Right. Well, to help you understand why I'm so glad to have the opportunity to speak today at the Bold Thinkers series, let me tell you a little bit about my world. I'm a health economist, been working at Abt for more than 21 years as a federal government contractor, mainly doing research for Medicare, for CMS. Working as a government contractor means I don't often get to express myself in bold ways, and I don't often get to speak in front of such a large audience of bold thinkers with our own Twitter hashtag and these fancy blue bottles up here. So it's a real thrill for me. I bet I'm the only person in the room that's worked on a federal report that was authorized by the Federal Report Elimination Act. That really makes you feel like your work is making a difference. I'll get back to that in a few minutes. I've worked on reports for the government where we weren't allowed to use the bold word recommendation, or even its less bold cousins, suggestions or options. No, we had to use the word considerations. If Abt ever does a timid thinker series, I'll pull out that report and present it to you. Well, guess what? Unless I missed something, I'm not under any of those constraints today. So I want to spend a few minutes this morning sharing with you some of my ideas about the quality-related provisions of the Affordable Care Act. And kind of three key takeaway messages I want to leave you with. The ACA is transforming and strengthening the quality of our healthcare system. Depending on how we align the different quality initiatives, we can help or we can hinder this transformation. And I want to give a high-level vision for how alignment of measures and reporting across provider types and programs and help us get the most impact from this transformation. So at Abt, I've had the opportunity to work on projects that focus on what I see as the three key ways the ACA is transforming and strengthening the quality of our healthcare. One, implementation of new quality-focused payment models. Two, development of new quality and performance measures. And three, improved public reporting of provider quality that gives consumers meaningful, actionable information. So we're definitely in the midst of a revolution in the Medicare program, a quality revolution. Initiatives made possible as a result of the Affordable Care Act are transforming our healthcare system into one that promotes greater value. Of particular importance, the ACA created the Center for Medicare and Medicaid Innovations, which is developing and testing several new payment models. The goal of these models is to achieve the triple aim of better healthcare, smarter spending, and a healthier population. How big is this transformation and how fast is it occurring? As Michael mentioned, last year the administration announced a goal of tying 30% of Medicare payments to quality or value through alternative payment models like ACOs or bundle payment arrangements by the end of 2016. Earlier this month, they announced that this 30% target was reached in January. It's 11 months ahead of schedule. There's also a number of initiatives focused on developing new quality measures mandated by the ACA and other legislation and making this information more accessible to consumers through provider ratings. I'm particularly proud to have worked with CMS on the development of 3 new claims-based measures: hospital readmissions, outpatient emergency department visits, and successful community discharge, that will be reported on CMS's Nursing Home Compare website starting next month and used in the provider rating system starting in July. Reducing hospital readmissions is a focus of a number of ACA initiatives, which also mandated several enhancements to the Nursing Home Compare website. Since implementation of the nursing home rating system in 2008, development of provider ratings has been an important CMS priority. Rating systems have been developed for health plans, dialysis facilities, home health agencies, and hospitals, with the hospital one based on patient care experience. And actually, the impact of these rating systems, it just continues to surprise me, the ways that they have impacts. After we got here this morning for this session, I found out about some legislation that had been proposed that would basically place some limits on the ability of nursing homes with a 2-star rating or lower to get mortgages. We can see the Capitol building down here for those in the room. I had this vision of them vigorously debating that particular piece of legislation right now, though they're probably not, but that's okay. Definitely not the type of impact that we envisioned at all when we first designed the rating system, but just to let you know that these things really make a difference and really can impact things in a lot of different ways. So these changes have resulted in a healthcare landscape that is much more focused on quality in terms of linking payment to quality, as in value-based purchasing programs, in terms of quality measure development, and in providing information to consumers through public reporting. But at least for post-acute care providers, who are the focus of my research, I've noticed that there's sometimes a disconnect across the various quality-related initiatives. For example, many of the quality measures that are reported on Nursing Home Compare and used in our rating system are not going to be included in the upcoming SNP value-based purchasing program. Why not? Are we reporting measures on Nursing Home Compare that we shouldn't because they're bad quality measures? Or is the value-based purchasing program not including some important measures that it probably should include? Shouldn't value-based purchasing and the rating system be more aligned? CMS has been exploring staffing measures based on payroll data for more than 15 years. Actually, that report I talked about at the beginning from the Federal Report Elimination Act, that was the first report that explored the use of payroll data for nursing homes. The Affordable Care Act mandated that a payroll-based system for nursing home staffing be collected, and after a lot of years, a system's finally being launched later this year. Shouldn't staffing, given the body of research that shows the important relationship between staffing and quality, shouldn't measures from that system be included in SNF value-based purchasing? Seems like there should be more consistency. And while we're talking about consistency, why is it that the Home Health Value-Based Purchasing Program, which started earlier this year, has more than 20 performance measures, while the SNF Value-Based Purchasing Program will apparently just include 1 performance measure? Seems like there should be some consensus on the number, the types, of performance measures, and we shouldn't see these types of big differences. One last thing while we're talking about consistency. Why is it that Nursing Home Compare is a 5-category system, 1, 2, 3, 4, and 5 stars, while the Home Health Compare rating system is a 9-category system, 5 stars but with half stars, so there's 9 different categories. Those are the kind of things that keep me up at night. Where's the consistency? With all the emphasis now on standardization across settings, it seems to me that there should be more of it. We should see consistency in the measures and scoring rules used across value-based purchasing programs. The same consistency ought to be seen between programs, and we should focus on including measures that can be used across care settings in addition to setting-specific measures. And we should include and make available to consumers information on provider performance that are used in value-based purchasing programs. So my vision is simply this: the development of a set of standardized priority quality measures that are aligned across settings. That way they can be used to guide selection of measures and serve as a common framework for both value-based purchasing and public reporting initiatives. CMS has done this to an extent across its physician reporting and value-based purchasing programs, but additional work is needed. I'm not talking about complete uniformity, but what I think is needed is agreement on market signals and measures across providers, with the goal of driving toward a set of measures that will most effectively drive the health system transformations facilitated by the ACA and promote informed consumer choice.
Thank you very much, Alan. I wonder, Mike, whether you'd like to react a bit to the observations on quality that Alan just made.
Sure, I'll try and be brief. So, in many ways, I agree. I will try and emphasize some of the areas where I don't, but just understand I do largely agree. The first one is somewhat semantic, which is we talk a lot about paying for quality or paying for value, and we want people into these types of programs, and then we count things like ACOs and a lot of the other types of episode payment models as fitting that category. Those aren't really pay for quality. They have quality components to them. Getting those measures right are crucially important, but they're fundamentally not we're paying for better quality. We're actually putting folks on a budget one way or another and adding some performance measures on top of that. It's really not fundamentally we're tying. People say moving from fee-for-service to fee-for-value. That's not what's happening in a lot of these other programs. They are basically broader bundled payment or global payment initiatives with pay-for-performance components. The pay-for-performance part is much smaller than the overall amount that folks are getting. But it is a transition away from fee-for-service, and I think that's important, and I do think the quality parts are important. The second thing I will say is a little more nuanced. So I'm a big believer in standardization, and many of the examples you gave, particularly on very like-minded things. Although when you change the scope of payment, in fact, we actually have a health affairs blog on this point that I believe is coming out today. So that's sort of a pitch. I might not be. Someone here from health affairs can tell me if it is, but I believe it's coming out today. If you change this, and it makes the point that if you change the scope of payment from fee-for-service to sort of a broader bundled payment, the quality measures you might want to include and how you want to use them are very different. In a fragmented system, the thing you're worried about is that the providers don't capture any savings related to the quality of what they do because they have a very narrow scope in the fragmented payment system. So you worry that a primary care physician, for example, can't capture any of the savings of good primary care, and that's a market failure, so you put a quality payment in to the primary care physician to do that. You might think the hospitals are getting paid more for having more admissions. You don't like more admissions, so you put a payment model in as a quality measure to reduce readmissions because you're trying to counteract the incentives that hospitals have to have more admissions and or readmissions. In a different payment model, a bundled payment model or a global payment model, some of those incentives that exist in the fee-for-service world don't exist. You can come to much broader population-based measures, things that wouldn't be very appropriate in a fee-for-service primary care world, but might be appropriate quality measures in a sort of more population-based orientation. And you don't have to worry about some of the incentives. So in a global payment model, you already have an incentive to reduce readmissions, for example, in a global payment model, because you get penalized if you have a lot of admissions, not because of some CMS penalty system, but because you're shooting for a target. So if you can reduce admissions, it works well. So you have to think through across the form and the scope of payment, the exact type of quality thing that you would want. And so again, I agree in terms of standardization. Too often you have measures that are intended to do the same thing with slightly different definitions, or very similar programs with slightly different things. But when you move across these broad programs, it's not clear you fully need standardization, and it's not clear we'll ever get to a completely good core measure set quite well enough. I think the more we can move to bigger, broader population-based measures and apply them to bigger, broader payment models, the better. And last point I will say is, in my mind, the measures are important. It's less about the measures and more about the measurement system. And you need to define the system of measurement to meet the intent of what you're trying to accomplish. Sorry.
Okay, no,
was long.
thank you for that exchange. I'd like to try and link this session to the first session, because I'm hearing a rather sharp contrast in terms of the nature of benefit design that was recommended in session 1 compared to the kind of benefit design questions that arise when we talk about Medicare. This may be because we're starting from such different initial conditions, but in session 1, I heard Karen Lynch talk about the design of different plans targeted on different groups, admittedly with sufficient risk adjustment to prevent this from being a profit development mechanism, but instead a mechanism designed to focus the appropriate care for people with different needs. Peter Lee talked about the restrictions on the range of choice that is available within Cover California, but still an immense difference among different classes of plans, at least because there are 4 metal tiers, but even within the tiers. But when we come to Medicare, we're talking about a benefit design that is very, very much more tightly constrained. And Bob, I didn't hear you calling for the kinds of benefit variations. I should say, we didn't call for the kinds of benefit variations.
Kimosabi.
That were discussed in session 1. So I'm having a little difficulty linking up the ideal world that emerged from the discussion during the first session and the kind of world we live in with respect to Medicare in terms of benefit design. And I'd appreciate if each of the 3 of you might weigh in on that. Since you spoke last as presenter, Alan, and you commented, Mike, Bob, why don't you start?
Well, there is within Medicare, and there would be within our recommendations, the Medicare Advantage program. And the question there is, how much variation do you permit those plans to exhibit? So, you know, and then I would wonder whether, and somebody in the audience undoubtedly knows the answer to this, whether when we're talking about the 65 plus folks and looking at them not in a single year but over the course of their remaining years, whether there is as much variation in what they need as there is when you think about people from infants to 64 years old. You know, but I'm listening to the first panel. I was wondering, you know, what we mean by insurance if everything gets too personalized. I mean, you think of something like your homeowner's insurance and you're protected from it burning down. But, you know, I live in a neighborhood where there are a whole lot of trees and they fall on the houses, you know, with regularity. And can somebody who is in a Geico plan that only does people who live on plains where there are no trees, you know, be one pool and then I get put in a tree pool. You know, I mean, it's.
Mike?
Well, I mean, I agree with exactly what Bob said. I would just add, there is a CMS demonstration project on right now in the area of value-based insurance design that gives the plan some discretion in terms of tailoring benefits to people with particular clinical conditions. And I think that potentially can be useful. We will see how many plans participate. I believe that Aetna we've certainly been talking to Aetna about this. I don't know if Karen's still here, but in any case, we have been talking to Aetna about this, and I think Aetna has really been a leader in some of these things. So I do think there is some flexibility, but I agree completely with Bob. The mechanism for that is probably best in a Medicare Advantage world than having too much variant on Medicare. I think your proposal, and again I agree with, is you have a basic Medicare program and then sort of a generous one to avoid some inefficiencies associated with separately purchased supplemental coverage.
There are special needs plans which actually
exactly.
do this already. And
Alan, did you get?
I'll just say I'm very focused on Medicare, so I don't really know much about insurance design outside of Medicare, so I learned a lot in the first session. But from the Medicare perspective, it's just a very exciting time. All these payment models being implemented and tested by CMMI. I think most of them, the evaluations are still ongoing, and we're still learning kind of about what works about them and what doesn't work. But it's, I think, a very exciting time to kind of see what the impact of those will be.
Good. One other question that I'd like to put to the panel before we go to the floor. There was a great deal of emphasis during the first session as well on both the potential for and the limits of consumers' selection decisions disciplining the world of providers. That the way I heard it from Peter Lee was that he wanted insurance purchasers to have some skin in the game, but not too much. That was what emerged in his discussion of the role of deductibles and separate categorical deductibles for different services or separate cost sharing for different services. What is the potential, in your view, for the role of consumer discipline in the Medicare program as compared to that for the under age 65 population for people not with disabilities?
I'll take a shot at that one. And I was hoping I wouldn't have to bring this up because CEO's in the back of the room and everything, but a few years ago we won, he mentioned the Clark Abt Award, which is for social impact, and it was for our nursing home compare project that had been around for a few years. And good evidence that providers were responding to it, quality was going up, consumers were using it, seemed to be informing choices, and everything was good. But then the ratings kept going up and up and up, to the level that we no longer believed this is all just improved quality. There's some coding changes, whatever you want to call it, going on in the system. I think it shows that the provider rating, this is just ratings without any link to reimbursement or anything like that, a very powerful motivator for nursing homes. So whether consumers were disciplined, I think there's some evidence out there, at least in my world, that shows that market share is increasing for the more highly rated providers and going down for the other ones. So some inference that does affect consumer choice, and I think it definitely affects providers. They pay attention to it. They want to do well. They want to present themselves well. So I think the evidence is pretty clear that it has an impact. And a lot of the work that we've been doing in recent years is to try to do something to counterbalance the fact that if you're using measures that are self-reported by providers, they may be less accurate than you'd like them to be.
Okay, we've come to that part of the program where you get to come back at the three presenters with questions of your own. And I'd like to see whether there are such questions. Don't be bashful. Yes, over here.
Hi, Brian Pagels with Forum One. I want to follow up on kind of that last point. I work with a lot of organizations who are kind of in the business of not just research and analysis, but also kind of advocacy and education for consumers and the decisions that they make. And I'm kind of curious to know your thoughts on not just whether Americans have better access to quality care, but do they kind of understand quality care? and what improvements could be made to kind of help in that education process and the decision making about how to choose better quality care.
Good question.
Let me build on that question and elaborate on the one I asked before. One way that improvements in quality can be encouraged would be through the individual decisions of people who are covered for insurance, the insured population. The other way is through alterations in the payment system that are imposed by insurers or by public policy through Medicare that alter the incentives. Lurking behind my question was a belief that the latter provides greater potential for promoting improved quality than does the former. And I'd like to see if we can get some reactions to that.
All right. I guess two different strands of questions here,
Yes.
but I'll take a shot at it. Kind of a big goal of the rating systems that CMS has introduced is to take information that had been publicly reported for years and try to make it a little bit more accessible and understandable to consumers, many of whom can't or don't want to go download massive data files from medicare.data.gov and analyze them and try to make their own decisions. There is a risk in a world where people use 5-star ratings when you buy stuff online or go to restaurants or stay at hotels that they'll pay too much attention to that. And part of the education efforts that we try to emphasize to folks is this is one tool, but it doesn't substitute for visiting the nursing home, talking to people, that sort of thing. I think going forward, a way that I think the information can be made more accessible and more useful to consumers is to try to make it more customizable to their situation. So maybe they can indicate on these websites what kind of care they're looking for. If they're sophisticated, maybe what types of factors are more important to them, and kind of have a more customized rating system. That's kind of something that's in our long-term vision. It's kind of still several years down the road, but with the development and implementation of some of the measures that we're introducing now, I think it's more feasible than it's been in the past.
So I agree. There's a big picture philosophical question. Do we rely on consumers or do we rely on payment? If I had to pick one, I would rely on sort of payment and that type of thing.
But you should use both.
They're not mutually exclusive. They should sort of work together. I will say that for a variety of reasons, not the least of which is budgetary, we are going to have a lot of cost sharing in the system. And so you might as well try and tailor that cost sharing in the sort of most effective way possible. I think that was the spirit of your paper with Bob, that, that said, we have to ask, why is the cost sharing there? Is it simply to shift cost to people, or are you trying to incent folks to do things? And in that model, going back to the Rand health insurance experiment, you want to figure out where the elasticity is, where's the moral hazard, how are people responding? We know that people respond both in the right way and maybe not in the right way from that earlier work, and that still remains to be seen. True, I think there are particularly challenges in the Medicare population for doing this type of thing. So if we really were going to start from complete scratch, I think we would design something that might be different in a variety of ways, but we are not simply going to make Medicare, the actuarial value of Medicare, just tons more generous, because I think the budgetary realities aren't going to let us make it a ton more generous. So if we're going to hit a certain actuarial value, we should try and design the benefit structure as effectively as possible. Some of that will be things like out-of-pocket maxes. I do think there are areas where you might be able to be a little more nuanced in the benefit design to push in the right direction.
I'm more skeptical, I think, than the others about the role of the consumer in a lot of this. Fine when you're having a MRI for your sore back or whatever, and you're perfectly sort of mobile and healthy and all of that. When you're in a chronic care situation, when others are making decisions for you, where lots of other dimensions come in besides the ones that you've defined and then measured, it becomes much more complicated. I remember being in a meeting where many years ago when ratings of nursing homes were sort of starting and people were all excited. Somebody asked the individual who was professor of health policy at University of Minnesota, why he chose the particular SNF to put his mother in, which was ranked dead last. And this guy studied the things, and he said, well, it's a very simple decision. My brother and I looked at where the nursing homes were, and this was one where one of us on our way home every night could stop by. And we thought keeping our eyes on what was going on was the most important thing that we cared about, as opposed to, 4 stars or 5 stars, 45 minutes away.
Mike?
I mean, there's a lot of places you can't do it. The question isn't that in some ways, it's really where can you? And so I'll just throw out one thing, and then I might have to leave. I don't know if there's a back door. Cost sharing for home care. Is that something that, we have cost sharing for a lot of things. Is that something you'd like to think through, given what you think is, I'm not going to advocate instant. I just want to be clear because I'm on TV. I'm not making any comment one way or another about the merit. I'm just saying there may be things that you think are sensitive to consumer demand in the Medicare program, and you might think that having the people access to those things with no first dollar coverage at all might not be optimal. Maybe it is. Again, I may have mentioned I'm not saying anything one way or another because I'm not bold, but I do think there are areas where you might think that you could do it. It's just a question of figuring out where they are.
I would mention one other thing in that connection, which is the old point that Milton Friedman made about markets, which is that not every purchaser has to be rational or be making decisions at the margin. What you need is enough people who are making decisions based on that consideration to police the market, and that can have, therefore, a very powerful effect.
And I mean, it can be completely rational to go to the poor home because it's very convenient to your house, but maybe if there had been 2 or 3 nursing homes as close, they would have used that information and gone to the better ones.
Yes, sir.
Yeah, but this isn't like buying bread, where the bread factories can pull a lever and a whole lot more bread comes out, to be sold in the store because it's the good bread. These are institutions often, or individuals, and you think, are we better rewarding physicians who are, quote, high quality by making them who are already overburdened with patients, even more overburdened, and their first reaction will be, I'm going to raise prices? Or do we want to think of regulatory and other education and other ways to raise the performance of those who aren't so good?
And there are things called peer pressure as well from groups of who are involved, who identify the bad actors and put pressure. Yes, sir.
I'm Chris Kumar. I'm a business analyst, and I worked at Abt Associates 40 years ago on health productivity issues, health cost issues. And today I teach business analytics here in George Washington University. So looking at the title, I thought, this is a question to both the sessions. I thought there is 5 years of experience, data experience on this one, and we have moved from 8 million to 20 million enrollees in the program, that you have a lot of data. And in business analytics today, we say that bold thinking has to involve big data analysis. And so I have a timid question. Given so much of an experience and so many contracts that you have worked on, you must be having a lot of data and data analysis. And the question arises as to what do those data tell in terms of, say, for example, before and after the ACA, what happened to the cost, what happened to the quality, and so on and so forth. So big data analysis support to come to some conclusions on, do we have a better access or better quality health care? What do the data tell? And I was hoping that at least there would be some talk about that And I wish maybe there will be another workshop like this, which will be focused mostly on that, in which people like me would be very much interested.
Mike, go ahead.
So I think the challenge with analyzing data is you need to figure out the counterfactual, and it turns out the counterfactual is never in your data. And so I'm a big fan of data analysis in general, and I think you will see a lot of sort of academic people arguing about what happened because of the ACA. It turns out they're not going to be arguing about the data that's in front of them. They're going to argue about the counterfactual. A lot of it's arguing about what would have happened otherwise. Some of the things seem clear. More people got coverage. The bigger things that's great controversy is this spending slowdown that we've seen. And there's, so I've been on the side that it was the work that we published in Health Affairs suggested it wasn't simply due to the recession, that there were structural things going on, but there's people that have a different view. We agree on what spending growth was. We just don't agree on what it otherwise might have been and what to attribute that to. And that's where I think the challenge in the data analysis is going to end up being, but you will see a lot of it in many, many academic sessions, I think, going forward, because it is a crucially important question.
We are doing a lot of big data analytics at Abt to evaluate. It's usually evaluating individual initiatives, not like the overall question of how the ACA itself has transformed system, but how have ACOs worked to achieve the triple aim? Or bundle payment care initiatives working like they're supposed to? What's been the impact of the Healthcare Innovation Awards? So those are all projects that are ongoing. Be a fun session to have to talk about those and some of the findings. It's just a little bit more detail than we could get into today.
Furthermore, there's the issue of there are data and there are data. I remember a discussion that Joe Newhouse and I had some years ago, not unique to us, as you will see, on what factors explain the difference in per capita spending between the United States and other countries. Could one identify quality characteristics in the data that would help one explain differences in spending levels? Joe, much more sophisticated than I on this matter, pointed out that the relevant data, although there are lots of them, were not available because of shortcomings in the way in which the data were collected. I had the brilliant idea at the start of the ACA that we could learn a lot about what administrative procedures worked best by comparing the way in which different states and presumably also the federally facilitated exchange made decisions on key matters. The data are not available, and to the extent that they are collected in such disparate fashion that they are not really comparable. So there are situations in which big data does constitute a magnificent gold mine just waiting to be exploited. But there are a lot of other situations in which tons of data are generated, but it's mostly noise rather than information. And with that, I think we've come to the end of our time. Was there one more question we had time for? Good.
Hi, I'm Tim McBride at Washington University at the Brown School. This session was about Medicare, and you mentioned that Medicare is a big fiscal challenge, and we're in the middle of a election that's sort of a train wreck that hasn't really talked much about Medicare's fiscal challenge. And since we have so many CBO experts on this panel, I'd like to ask is there a solution to the Medicare challenge that is lurking, that's not being discussed, that maybe will be revealed on January 20th, that you can tell us what it is, that out in the hinterlands that is it, Mike mentioned that, we've saved 1% or so from the ACOs, and so, can you reveal it to us?
I think there's a short answer to this question, but Mike, you'll get a chance. But if we gave it to you, we'd have to kill you.
Okay. Now I can't say. I have to change my answer. Actually, I think you want to go?
No, I want.
First of all, when we talk about things like these new payment models saving 1%, that's relative to a counterfactual in which, in fact, the fee-for-service system has saved a lot, in part because we've had very low fee updates. I think the issue that arises in terms of the Medicare challenges, Medicare, in my personal view, through the ACA, is on a much more sustainable footing than it had been prior to the ACA. but we do have some challenges in Medicare, more people. So just to be clear, that's better than not having more people if you think about what the alternative, right? So more people on Medicare is a good thing, but we do have this fundamental societal challenge about are we willing to actually pay for them, or do we simply have to make that cohort of people kind of pay for themselves in a variety of ways, or have the delivery system just care for this greater group of people with just the same amount of money and work it out in efficiency. I'm not sure we know exactly. I do think that the mechanisms put in place by the Affordable Care Act are as reasonable as any mechanisms that I have heard to achieve those goals. It is not clear that they will be successful at doing that, or that they will be successful at the magnitude they would need to be to avoid a greater share of GDP going to Medicare.
Bob or Alan, do you wish to add anything?
Well, I think inevitably a greater share of GDP is going to go to these programs than some people would hope. You know, I think while the Affordable Care Act is important in what it's done, as much will depend on what happens in the private sector and the extent to which employers and private insurers are willing to, you know, hold the foot on the brake, and that this is all politics. It comes down to. So I think there's, you know, if we just look at the last few years and the amount of sort of unanticipated reduction in Medicare spending, even way over and above what the biggest optimists were thinking when the Affordable Care Act was passed, you know, there's reason to be cautiously optimistic that, you know, we are moving in the right direction, that people's attitudes about this topic are quite different from how they were 5, 10, 15 years ago. And that makes things possible in the political realm that weren't possible before.
To keep Medicare at a constant share of GDP, you need basically Medicare per beneficiary spending growth to be GDP minus about 1.5. That's just because of the demographics. That's way outside of the realm of anything we expect that any of these types of things can do. That doesn't mean we shouldn't do them.
You know, and there's reason to be skeptical about some of the measures that we've taken. You know, Michael went on about what the physician updates will be in the future, you know, saying that the sustainable growth rate mechanism wasn't sustainable, but somebody might ask, you know, nominal increases of 0.5 percentage point a year, you know, for 20 years, how sustainable is that?
Would you thank each of the panelists for their contributions, and we will move on to the next part of the program.
Joe Newhouse is the Harvard University's John D. MacArthur Professor of Health Policy and Management and heads the Interfaculty Initiative on Health Policy. Joe is near and dear to folks like me at Abt Associates because he has been on the Abt Associates Board of Directors for the past 15 years and has made significant contributions to us in that realm, as well as in his health policy work. So thank you, Joe.
Thank you, Terry. I'll try to be brief. When I was about 8 years old or so, my favorite time of the week was Thursday nights at 6:30 because the Lone Ranger came on. I took Bob's allusion to Kemo Sabe. And the Lone Ranger always opened with an announcement that we take you back to the days of yesteryear. And so I'll, depending on your definition of yesteryear, I'll take you back to 2009, 2010, and try to channel the thoughts of those high in the administration and on the Hill about what they were thinking about the ACA would be like 5 or call it 6 years later. And I'd like to divide that into substantively where they would be and politically where it would be. So substantively, I think the ACA has probably succeeded near the high end of any reasonable expectation on the part of those in the administration. And I thought Richard Frank did an excellent job of summarizing the 20 million with insurance, the slowdown in cost, whether or not that's causally related to the ACA, but that was, as Bob Breyshar said right at the end, I think they would have been having a party about the cost growth that's been experienced. And finally, one thing that Richard touched on that I'm not, that I think has been a big success is CMMI and the innovation in Medicare. He was absolutely right that I didn't change my slide, that Medicare was the 800-pound gorilla of the healthcare system that seemed to be somnolent for many years, and then I changed it to it was the 800-pound gorilla that was beginning to stir, and now it's kind of in full motion. And I change my slides every year now about Medicare. Substantively, I think the ACA has gone, despite the glitches of healthcare.gov and so forth, I think it's gone about as well as the proponents of the ACA could have hoped for. And politically, I think it's probably gone about as badly as they could have hoped for. Expanding health insurance to 20 million people was inevitably going to involve a lot of redistribution, and not just from the healthy to the sick or the high income to the low income, but geographically and depending on what kind of insurance one had at one's place of employment, et cetera. And in part, the American political system tends to resist that, but in part, there's clearly a geographic variation in tastes for redistribution, which we are seeing play out in the election. So I think a lot of ACA proponents, I would put myself there, thought that once the ACA had made it past the Supreme Court and made it past the 2012 election, that it was basically there, and that probably is still the way to bet. Damon Runyon once said, in a fight between a big guy and a little guy, the big guy doesn't always win, but that's the way to bet. But let's suppose if I take the Republican presidential candidates and their congressional candidates at their word, and they sweep the table in November and repeal the ACA, although maybe not the Medicare provisions. What would be the legacy of the ACA in that event? And I think a lot of it does go to the reform of the delivery system that the ACA initiated, and particularly the fact that Medicare is now an active participant in the change in the delivery system. And I also ask my students, why do you think major delivery systems are now willing to take risk when their business model was fee-for-service for decades? And there can be a lot of answers to that, and I'm not certain I've got the right one, but one I think is potentially an answer is that the old business model was stopping to work for them, that the number of uninsured was becoming so large that the shift of cost to the insured that was happening was just torquing their delivery of services and their possibility of being financially viable. So I think the delivery system itself has embraced delivery system reform, or at least parts of the delivery system have embraced it in a way that I think is a very positive outcome, and I think will be one of the legacies of the ACA. So with that, let me thank you for coming and thank Abt for putting this on.
Hi, everybody. I'm Kathleen Flanagan, the President and CEO of Abt Associates, and I want to add to Joe's thanks for the 200-plus people who've been in the room this morning listening to these great discussions and contributing yourselves with terrific questions. Let you all know that on October 27th, we'll have another Bold Thinkers event right here, 9 to noon, the topic of which will be unveiled this summer. So stay tuned to all the Abt communications and Twitter feeds and all the other amazing social media that's out there that I'm not terrifically good at this point, but I'm learning. And have a wonderful day.